We're next going to discuss headaches. Headaches can be either primary or secondary. In primary headaches, the headache itself is the illness. Types of primary headaches include tension, migraine, cluster, and Indomethacin responsive headaches. In secondary headaches, the headache is occurring secondary to another condition. There are many causes of secondary headaches, such as infection, tumors, and trauma, but we will review 4 in particular here: Thunderclap headaches, Trigeminal Neuralgia, giant cell arteritis, and medication overuse headaches. Tension headaches are the most common form of headache and classically cause a continuous, bilateral, dull, aching pain. The pain is generally mild to moderate. Sometimes they are described as a tight band around the head. Tension headaches can have other associated symptoms like loss of appetite, nausea, sensitivity to light, or sensitivity to loud noises, but if more than one of these features are present, you should suspect a migraine headache instead. Tension headaches occur at some point in life for the majority of people. Given that tension headaches are quite common and generally mild, they rarely result in presentation to a physician for treatment. Pain from tension headaches can usually be controlled with non-opioid analgesics like NSAIDs, aspirin, or acetaminophen. Sometimes combining an analgesic with caffeine results in greater control of the pain. Migraine headaches are usually unilateral and result in moderate to severe pounding, pulsing pain. They last anywhere from 4 hours to 3 days. During migraines, patients feel nauseous and experience worsening of their pain from bright lights or loud noises, as well as from performing normal day-to-day physical activity. Because of this, patients with migraines often prefer to lie down in a dark and quiet room. Migraines are common, occurring in about 10% of the population, and are the most common type of primary headache seen by physicians. Migraines are more common in women. Migraine headaches often have a recognizable prodrome, occurring hours to days before the headache begins. However, a minority of patients will have an aura immediately before their migraine, which lasts for less than an hour. Auras are thought to be a manifestation of cortical spreading depression, a type of abnormal electrical activity that occurs before a migraine. When cortical spreading depression occurs in the occipital lobe, the patient experiences visual auras. Visual auras include scintillating scotomas, which are shimmering lights followed by partial vision loss, and fortification spectra, which are flashing zigzag lines that expand outward to involve a visual hemifield. Drawings of what fortification spectra look like to patients are shown here. Auras can also manifest as somatosensory symptoms, like numbness and tingling. They pose the greatest diagnostic dilemma when they produce signs that can also be manifestations of stroke, like aphasia, hemiplegia, or weakness in eye movements, called ophthalmoplegia. Treatment with triptans can be used for treating acute migraine headaches. Examples of triptans include sumatriptan and rizatriptan. Triptans are selective serotonin 1B and 1D receptor agonists, and partly work by producing vasoconstriction in meningeal arteries. They should not be used in patients with a history of coronary artery disease, stroke, or uncontrolled hypertension. Dihydroergotamine is a less selective serotonin agonist and can be useful for breaking a refractory migraine. Dihydroergotamine also has the same contraindications as the triptans. As both triptans and DHE are vasoconstrictors, they should not be used together. However, NSAIDs and other non-opioid analgesics can be used in combination with other meds. Antiemetics like prochlorperazine and metoclopramide are helpful as well, particularly for controlling nausea during migraines. Treatment of migraines with opioids is not recommended. Lifestyle interventions are an important way to prevent migraines and include regular sleep, scheduled meals, and avoiding food triggers such as chocolate, aged cheeses, and alcohol. Pharmacologic agents are used prophylactically when patients have frequent migraines or have complex auras like hemiplegia. There are many different classes of agents that can be used, and a particular agent can usually be chosen based upon patient comorbidities. Antidepressants including SSRIs, SNRIs, and tricyclics can be used. Particular anticonvulsants, namely topiramate, valproate, and gabapentin, are effective for preventing migraines. Metoprolol, a beta-1 selective beta blocker, and propranolol, a non-selective beta blocker that blocks both beta-1 and beta-2, are both effective. The non-dihydropyridine calcium channel blocker verapamil can be used. Calcitonin gene-related peptide inhibitors are a new class of medications that can be used for migraine prophylaxis. Most CGRP inhibitors are monoclonal antibodies given by subcutaneous injection, but new small molecule CGRP inhibitors can be administered orally. Lastly, Botox injection in the scalp, neck, and shoulders can be used for preventing migraines that occur more than 15 days per month, possibly through modifying the release of substance P. Cluster headaches are a rare type of primary headache. Cluster headaches are very intense intense, severe attacks of unilateral pain around the orbit or temple. Attacks last shorter than migraines, usually around 30 to 45 minutes long. During attacks, there are unilateral autonomic changes, which can be seen as eye redness, tearing, ptosis, meiosis, and rhinorrhea. The reason why they are called cluster headaches is that they occur in cycles, where a patient will have a run of many cluster headaches over the course of a month or two before they temporarily remit. Ethanol is commonly a trigger during a cluster. They are significantly more common in men than women. There are treatments you can provide during cluster headaches to help terminate the pain. Interestingly, supplemental oxygen can be given to treat an acute cluster headache. Triptans and DHE are also effective. Verapamil can be used to prevent attacks. Glucocorticoid steroids can also be helpful during clusters of attacks. A particular group of headaches are called Indomethacin responsive headaches because they show complete response to the NSAID indomethacin. Ice pick headaches are characterized by sharp, stabbing pain lasting for only a few seconds in a localized spot on the head. Chronic paroxysmal hemicrania is a continuous, one-sided headache that can last for months. Exertional headache is a transient headache that occurs during physical exertion, like lifting weights. Coital headache is a headache that occurs during or immediately before orgasm. So now we'll get into the secondary headaches, starting with thunderclap headache. Thunderclap headache describes how patients experience the pain. It is a very severe headache and starts very suddenly, like a thunderclap. When a patient describes a very sudden onset headache as the worst headache of their life, you should suspect a thunderclap headache. There are two major causes of thunderclap headache you should always consider: subarachnoid hemorrhage and reversible cerebral vasoconstriction syndrome. Subarachnoid hemorrhage is a very important cause of thunderclap headache, and we'll discuss it further in another video. Reversible cerebral vasoconstriction syndrome is temporary vasoconstriction of intracranial arteries. It can be induced by vasoactive serotonergic drugs like triptans, amphetamines, cocaine, pseudoephedrine, and SSRIs. The vasoconstriction can cause focal neurologic deficits in addition to the thunderclap headache. These usually improve with time. On angiography, there is a beads on a string appearance of the intracranial arteries coming off the circle of Willis. Giant cell arteritis is a type of vasculitis affecting branches of the carotid artery. It occurs primarily in the elderly and is more likely to occur in women than men. It presents as a throbbing pain in the temples due to the involvement of the external temporal artery, or as pain in the jaw after chewing, called jaw claudication. It commonly occurs in patients with polymyalgia rheumatica, a rheumatologic disease that presents as diffuse muscle pain, stiffness, and fatigue, with elevated erythrocyte sedimentation rate and C-reactive protein. Biopsy of the temporal artery shows multinucleated giant cells on microscopy. Giant cell arteritis necessitates rapid treatment with high-dose corticosteroids because of the risk of blindness from ophthalmic artery involvement. Trigeminal neuralgia is brief electric shock-like facial pain in one or more divisions of the trigeminal nerve. Trigeminal neuralgia can be a presenting sign of multiple sclerosis. Bilateral trigeminal neuralgia is particularly suggestive of multiple sclerosis. The pain from trigeminal neuralgia can be triggered by lightly touching a trigger zone, or even from chewing, talking, brushing teeth, or from a cold wind. If trigeminal neuralgia is not due to a structural lesion affecting the trigeminal nerve, it is commonly treated with medications like carbamazepine. Another treatment is surgical decompression of the trigeminal nerve by putting a small sponge between the trigeminal nerve and the superior cerebellar artery. Medication overuse headaches can occur in patients who get migraines or tension headaches and use acute therapies very frequently. This can include all medications we discussed for acute abortive treatments of migraines, including dihydroergotamine, triptans, NSAIDs, aspirin, acetaminophen, and also medications that are not recommended, like opioids. Medication overuse headaches do not respond to abortive therapies. Instead, the agent that is being overused should be discontinued. Prophylactic medications should be used instead.